All right, we're going to get started. Welcome, everyone, to CMM's annual Infection Prevention webinar. My name is Kathleen Misovic. I am be your moderator today, and I am the managing editor of CMM Magazine. So we can go on and talk about the topic on the next slide. This is just introducing. I've already talked about myself. Also helping us on this webinar is Martha Schmidt. She is the person behind the scenes, and she is kind of doing all the tech stuff with this webinar. And then I have my colleague, Elizabeth Christensen. She will pop on later today during the webinar, and she will moderate the questions. So next, we have a few housekeeping notes. So before we get started, feel free to interact. You can use the chat message section. You can also use the Q&A section. It's okay to make noise, or if your dog barks, that's okay because you'll be muted. And if you want to review this webinar after today, we will be sending you a copy of it, so you can always watch it again at a later date. So let's go on and learn a little bit about ISSA. CMM is owned by ISSA, which is changing the way the world views cleaning and facility solutions. It's a global industry association from manufacturers, reps, wholesalers, distributors, and CMM's group, which is building service contractors and in-house cleaning professionals. If you haven't already, check us out on the website, ISSA.com. So next we'll learn about ISSA Healthcare. It's a section of ISSA. They connect a diverse community of healthcare, cleaning, and industry professionals to educate, train, and present evidence-based strategies to create safer care environments and reduce infection risks. I want to let you know that they are having a seminar coming up early May. You can learn more by going to ISSA.com healthcare. So, and be sure to register. So next we can go on. I'm going to introduce you to today's panelists. And after I introduce them, they're going to tell you a little bit about themselves and their background. First, we have Sophia McRae, and she is Vice President of Operational Strategy at Crothall Healthcare. Take it away, Sophia.
Thank you so much for having me, and it's great to connect with you, my fellow virus busters. It's a pleasure to serve you as well. I've been with Crothall Healthcare for 19 years now. My background is in biochemistry, and it's our mission to really enforce cleaning and disinfection protocols with partners like you. So we're happy you're here with us today. Thank you.
Thank you, Sophia. Next, we have Rodney Rohde. He is Chair and Regents Professor with Texas State University. You're on next, Rodney.
Good afternoon, everyone from Texas. It's nice to be here. Thank you again for having me. I have about 30 years plus experience in public health and medical laboratory infectious diseases. So that's primarily my specializations.
Great. Next, last but not least, we have Barbara Strain, who is ISSA Healthcare Advisory Council member. You're on, Barbara.
Great. Thanks, Kathleen, and hi to all my fellow virus busters. I love that, Sophia. So I have over 40 years of experience working in hospitals. I'm a microbiologist, virologist by training, and also a value analysis professional.
All right. We will go on to the next slide, which talks about kind of what you want to know. So the audience kind of put in the chat, what do you want to learn from today's webinar? So, and this will kind of help us gauge at the end, the question and answer section, what other concerns we could talk about. So, and after we've wrote a little bit in the chat, we're going to go on and talk about the flu. So, and other illnesses. Even though it's almost 70 here in Chicago, by Saturday, it's going to be back to 30. So it is still cold and flu and other season. So I'll start with the panelists and explain why is it that some illnesses are more prevalent in the winter, and is it worthwhile for facilities, healthcare facilities, schools, and others to actually track illness rates in the area? We'll start out with Sophia.
Sure. So let's think about this for a minute. So winter is, in my opinion, the most perfect storm. I think people are closer together, the air is drier, viruses survive longer, and our natural defenses aren't really operating at peak efficiency. So in just watching the Super Bowl, I was trying to think of an analogy here. I'm like, viruses love winter. I consider it their Super Bowl. So we know that cold weather is pushing people inside, windows are closed. And in the healthcare settings, waiting rooms and inpatient units are so much busier. So as we think about people being closer to one another, it's easier for respiratory viruses to spread throughout droplets and aerosols. I'm a research geek or nerdette, and I know that research shows that influenza specifically transmits more efficiently in low humidity and lower temperatures, and our respiratory systems don't really defend as well in dry air. Through learning through biochemistry, inside your nose airways, you have a natural cleaning system. We learn about tiny hair-like structures. They're called cilia. They constantly move mucus upward and out of your airways. And that mucus is actually trapping viruses and particles before they get deep into your lungs. So with that, mucus layers become more thick and less mobile. So viruses are easier to get past our first line of defense. So we have to think about that. We have to think about holiday travel and large gatherings, introducing new strains into communities and facilities. So while we think about that, I think from an EVS perspective, I sat with the question, is it worth tracking? I do believe that data helps us adjust EVS coverage, isolation, room readiness. We tend to look at PPE burn rate. We want to provide proper messaging to visitors. So I do think that reporting it to EVS operators equips them with being in a position to shift from reactive to predictive operational strategies. So we can staff appropriately, we can anticipate ED boarding and be true partners to our clinical care teams, providing the highest level of care.
All right. Rodney, do you have anything to add to that?
Yeah, I just echo every bit of that. That is all absolutely true. I think some other points that I would make is that one, viruses are probably the most notorious microbe we know. They are well known to mutate. Influenza, especially, is an RNA virus, and I often tell my colleagues and family members that RNA viruses are especially problematic because they mutate. And RNA, and specifically flu, is made up of multiple subunits in its genome. So its DNA and RNA can really get a little wacky at times, and that's why our vaccines, even though some people may think that they're, 100% effective, they're not always 100% effective. So we're always trying to catch up to the virus's changing and its mutation rates. That's why in any given year, even if you're vaccinated, which I firmly believe in, you still may only be protected 50, 60, 70% against the infection. But all the data shows that that will help you prevent severe illness and hospitalization. Another thing to keep in mind with flu virus is that it is found in multiple reservoirs, swine, a lot of fowl. You've probably heard of bird flu. And so that also plays a component, even with the migratory patterns of these animals as they move into different regions. So geography kind of matters. It's why you see a flu season in one part of the world, like Australia at a certain time, and then mostly in the winter here, kind of depending on where you're at. And so all of those reasons, and definitely what Sophia was talking about with respect to indoors, just our ability to kind of navigate that space. And the other thing I think that as Americans especially can relate to this, we have this really bad habit that we need to break. We go to work no matter what, each and every day, and a lot of us show up sick, and that plays a part in prevalence in certain times of the year. And it's absolutely worthwhile to track flu. I'm an epidemiologist, an old public health microbiologist, and you're flying blind. You're absolutely flying blind if you don't know the data and what's happening on the ground. So knowing surges on hospital ERs, knowing the types of variants that are in your area is completely important at all times.
All right, that's a great point. And on to Barbara.
All right, I'll be at the back of the parade trying to clean up after all the great floats and horses have gone by. I want to echo everything they've said because I said all the key points. The other thing is, but you have to watch out for all these newer things that are occurring during winter. So it's not just the usual suspects, but we can't forget about respiratory syncytial virus and colds, COVID, which can now occur anytime. But everything really sort of hinges on that winter aspect that we're talking about. We get flurries of activity, notice the hint to snow, but flurries of activity different times of the year. But in that winter, I live in a college town. Students leave, and then we take a deep breath because they will be back and they'll be coming from all of their events. So that tracking is so important because what's happening in your area may be an epicenter versus other areas. So, as Sophia said, you have to be prepared and keep following.
All right. Now we're going to get more specific. Flu. We've heard that it's a bad flu season. Take it away. And what do you think about that, Rodney?
Sure. So as we just mentioned, if you've been paying attention at all to any of the national or even global news around flu virus, it is absolutely up and running again this year. Uh, More troubling is if you're looking at pediatric flu. So last year we know that we had several hundred pediatric deaths due to influenza. This year we're kind of on the same trajectory. Hopefully that will slow down. So we absolutely see this kind of troubling rise in flu activities. Facilities can contribute to this in ways that most of you probably understand. Uh, Going back to what Sophia said, just the interaction of more people inside closed spaces, the air is different, the humidity is really a key factor for flu virus, especially in the dryness or the moisture that's available in the air. So it survives longer. Viruses are known to only be able to replicate and live in a host like a human being or an animal or an insect or a bird or whatever you want to talk about. But these types of conditions can allow that virus to stay viable on surfaces, and that's a topic we're going to be talking about today. So whether it's the surface of something you commonly touch, whether it's patient to staff or staff to patient, or different types of instrumentations that might be utilized during that phase. So facilities can take the types of steps that most of us think about around education. Education is a really helpful thing to remind people about hand hygiene, to remind people about how they're interacting with sick people. If you're sick, stay home. If you're in a hospital, everyone might be sick within respect to patients. So you want to be more careful in how you handle those patient rooms and the cleaning of those patient rooms and so forth. So all of the above is important. And then again, I mentioned this earlier, but vaccination still remains a key part into helping lower or reduce the ability of viruses to maintain presence in a reservoir or in an area. So immunization is always going to be key in a way to help reduce some of those transmission rates.
Thank you, Rodney. Barbara, what is your take on some of the steps facilities can take to combat the flu?
Preparedness. So, not waiting until it's probably in your area or something is happening, but you need to have a full out plan. You have to include employee health, infection prevention and control, epidemiology, environmental services, any of the nursing units, et cetera, and have sort of a plan that you can execute it when someone of authority uses all those elements and say, okay, we're executing the plan. And that plan should go down as far as each different area and what they have to do to prepare. Because once it sort of comes into your doors through coughs that people think are just a cold, or not wearing masks when they should, or starting that early, then it might be a little late to sort of prepare. And now you're in a responsive mode. So being prepared with a plan and who kicks that plan off and when is it executed and does everyone have a copy of the plan and what they're supposed to do?
All right. Planning is key for sure. Sophia, do you have anything to add?
Yeah, I thought both of my colleagues did a phenomenal job. I love how Rodney kind of categorized that transmission isn't really just about proximity, it's about workflow, especially when it comes to high touch surfaces. And Barbara, you're spot on when it comes to maintaining strong project planning and interdisciplinary communication between all departments, because I think when we collaborate effectively together, escalation becomes controlled instead of chaotic. And then we can really focus on prevention so we can really drive operational reliability. So I think they covered it perfectly.
All right, and now we're going to talk about a really fun illness, which I talk about in jest, not just for cruise ship, norovirus. I think there's a thought that once one person gets norovirus in a spot, everyone's going to get it. Do you guys think that's true? And what cleaning protocols are most effective for eliminating this virus? And we'll start with Barbara.
So think of the hospital like a cruise ship. It just isn't sailing anywhere. It's sort of a captive ship at dock. But we learned the exercise with Ebola back in a few years ago is that once someone sort of crossed your threshold with anything that looked like symptoms, you had to sort of get really actively involved in how you were going to do that. And all the viruses act differently. Norovirus can spread very quickly. It can also last up to 2 weeks once you're feeling better and can still transmit and spread the virus. So you have to be very aggressive with how you're going to deal with it, and because it can spread very widely, because it can be transmitted through food prep, through contact with either vomit or feces or a variety of all those wonderful body fluids, and it can just spread very quickly. One of the things we also have to consider, not just norovirus and stuff, and I know we'll probably get to it, but we also have to talk about, are there any treatments and things we can do to keep the levels of the virus down within people and stuff? But it's like a cruise ship and it will spread. And so you have to implement a lot of different cleaning protocols that will address the uh, bathrooms, anywhere where there's congregation of people that might be extruding the virus, ED, heightened awareness everywhere.
All right, thank you. Sophia, your thoughts on norovirus?
Yeah, I agree with Barbara. I think the difference between an isolated case and an outbreak often comes down to speed, communication, and strict protocol adherence. So, similar to what Barbara said, our teams have strict protocols around cleaning and disinfection. They partner with respective IPC and clinical teams. We immediately defer to the appropriate EPA lists, whether it's relative to norovirus and emerging pathogens, and ensure that we're following manufacturers' instructions for use and appropriate application at all times. I know Barbara mentioned even something like vomit and diarrhea as far as a method in which it spreads. Our teams are trained to have dedicated spill kits. They're trained on containing aerosolation, following appropriate PPE. So we don't take this lightly. We consider enhanced terminal cleaning every step of the way. This one keeps me up at night. I think earlier Rodney mentioned PTSD, related but unrelated. But I was actually in California when the ship with the patient zero from coronavirus was approaching the bay. So to just see where that could lead, I think collectively everyone on this call has strict protocols to ensure that norovirus is contained when appropriate.
Thank you, Sophia. Rodney, do you have any more insights on cleaning protocols or prevention strategies for norovirus?
Just some quick thoughts. Again, echoing everything that was said, all good stuff. One of the things to keep in mind about norovirus specifically is that you really want to think about a bleach-based cleaner. It's actually quite resistant to the alcohol-based hand cleaner, so keep that in mind. And as Barbara alluded to, this is one of the most fast-acting and it pretty much knocks you down when you get this. I've actually had this. I was diagnosed with this several years ago during Christmas. That was a lovely way to bring in the holidays. It can actually be a little dangerous. You can really dehydrate quickly. It is quite a fast-acting stomach and intestinal virus. So if you do have it, make sure you're monitoring yourself or your loved ones because it can get pretty dangerous quickly. And then the last piece, just to add on here, if you're in any kind of a way of preparing food or caring for people, you really want to make sure you have been cleared of symptoms for several days, if not a week or so, because to Barbara's point, you might still be shedding virus, and you want to make sure you're not helping elderly people or preparing food or things like that because it's easy to spread.
Thank you. So, okay, we've talked about flu, norovirus. Next, we'll kind of see if there's any other virus or culprits. We can probably go through this briefly as I think we talked about a lot of stuff. But I'll start with you, Sophia. What other illnesses that we might not have mentioned are you always on the alert for this time of year?
I know when Rodney mentioned the pediatric experience earlier, it instantly made me think of RSV. We know it spreads through respiratory droplets and contaminated surfaces, similar to influenza. So that's at top of mind after what he mentioned. I think of rhinovirus, other common respiratory viruses. There are a lot of issues with gastrointestinal viruses right now. So to name a few, I know the team may have more.
Okay. Rodney, do you have more?
Yeah, a couple more. It's on everybody's mind right now. Measles. Measles and actually, unfortunately, mumps is now making a comeback due to we're probably going to lose our measles elimination status. I would expect that to happen sometime this year. And so that's something to be cognizant of if you're someone that has never seen it, right? So in the U.S., what we're kind of watching for is not only physicians, but other healthcare professionals and laboratorians, because we haven't actually seen it in our lifetime, depending on your age. So to keep that in mind, you may be dealing with something you haven't seen before. We've also dealing with adenoviruses and other types of things. Again, SARS-CoV-2 is still roaming around. And so unfortunately, we have, a top 10 for sure to kind of keep our eyes on as we're always dealing with these things in the winter. But we may be seeing some reemergence of new agents this year.
Oh, okay.
Yeah.
Barbara, do you have anything to add to that sobering thought? So,
Yeah, it's all when we get done with one of these, people actually say, I'm never doing this again. I'm going to stay in the house. One of the things I wanted to bring out, not that we haven't mentioned all of the viruses, there are other bacteria this time of year with strep pneumo. You've got a variety of the normal things you're dealing with, MRSAs and all those sorts of things. But it brings a conundrum, and that is not everything is killed by the same disinfectants. And your practices for cleaning before you disinfect might be altered as well. And the other thing is that if you made a matrix of everything that might be present at any given time that you have to take care of, you may find one or two common disinfectants. But the other side of the coin that people may not sort of take into respect, and why we wanted to do this webinar for lots of different reasons, was about the surfaces. And that's what we're trying to focus on, is to make people aware of if you're dealing with a bed or a countertop or a glucometer that goes bed to bed, tile floors, anything happening in a patient room or public restrooms, you also have to comply with the IFU for those. And so you've got this sort of triple or quadruple threat of what organisms and things do I have? What should I be using and what can I use that is effective? So I don't want us to lose track of all of that, just talking about the actual bugs themselves, because we do have to bust them, which is the whole point of all of us trying to talk today.
true. And as you mentioned, also to talk about surfaces. So next, we're going to have our people in our audience. Please go in the chat and let us know what type of facility you maintain and what surfaces and building areas do you find the trickiest and most challenging to clean and make sure that you've busted all the germs. So, and please feel free, as I said, to share your ideas, and then we'll go on to talking about some problematic surfaces. With the next slide. So, all right. So we'll start off with Rodney. What surfaces do you think that environmental services and cleaning professionals need to pay attention to because they're most likely to harbor pathogens? And which ones do you think that they kind of forget, not on purpose, but just they kind of don't think about them?
Yeah, so I mean, there are so many, right, especially within a healthcare facility. I often, when I talk about this, I'm always reminded we're focused on healthcare, right? We're really focused, we're zeroed in on that. But as I begin this conversation, and my colleagues can join me in a moment, this is also community, right? So wherever you're at, because you're constantly interacting at home, work, perhaps healthcare, maybe you're visiting grandma in a nursing facility, maybe you're taking the kids to their pediatrician. It doesn't matter. And really, I often talk about this, and Linda Leibert's heard me say this, that really a building is a living organism. It doesn't matter what type of building. Barbara's talking about, a cruise ship is really just a hospital without being in the ocean. And that's a very good analogy. So always kind of remember, no matter where you're at, whether you're at home, you're at work, you're at school, or you're walking into a hospital or the ER, you're going to be dealing with surfaces. And those surfaces have absolutely different types of microbes growing on them. Now, risk can be different. Certainly, if you're walking into an ER during flu season, chances are you're going to be running into people that are very sick during flu season or any other type of agent you're dealing with. So there is risk kind of thinking about where you're at. And generally, I'm all, and you guys have heard this and you can talk to the audience as well about this, what we kind of consider commonly touched surfaces versus maybe some that aren't touched very often. So there is this kind of stratification, bed rails in a hospital, right? Curtains, certainly instrumentation, individuals' hands are surfaces, right? And so all of those things are the types of things that you might want to be thinking about with respect to cleaning. And sometimes I think many of us know that the really difficult things to clean are what we might avoid. If you've ever looked into an ICU room or a NICU room, it is just a jungle of cables and instrumentation and lots of beeping noises and lots of high-tech computer systems and what have you. And that's a little tricky. How are we going to clean that? And so those are the types of things you really want to work with your EVS professionals and others that kind of know about those devices. There may be certain types of disinfectants or agents that you should only use on certain things. There's certain dwell times. There's certain, ways to do that.
All right. Barbara, your take on really problematic surfaces.
Sure. The bathroom is always one of my focus target areas, whether it's public restrooms or the restroom within a patient's room, is once you turn on a faucet, once you flush a toilet, or if you still have hoppers, if you've got an older hospital, that just creates an atmosphere in which organisms that might be trapped or inadvertently in, or even if it's the norovirus or others, you're making these aerosols. So whatever you're doing when you're cleaning is you might start with those, and so then you continue to knock them down as they might get spread. But it's anything and everything that could be touched in a room. People often talk about high touch areas, but if you think about it, if you have aerosolized particles that could germinate somehow, whether they're a bacteria or a yeast or whatever, they could land anywhere in a room. So we don't want to get panicked about all this. Rodney was correct when he said risk levels. So in those processes that you're writing down for either SLAs you're doing with areas or protocols for um, epidemics or pandemics or just breakouts of things. Make sure you're starting with high risk to low risk, but you need to talk and learn about what's going on in those areas because sometimes they can be switched for various reasons. Like during COVID, certain units were turned over into COVID or emerging pathogen units that may have been different units before. So, is everyone aware of that? So you just have to be cognizant. Even wheels of wheelchairs, stretchers going into a room from an outside floor, that floor, how was it taken care of? How often was it looked at? When were wheels wiped? Various things like that. So thinking about all this systematically can only help.
All right. Sophia, are there any systematic or other kind of tactics that you can explain for surfaces?
Yeah, great point, Barbara, on the aerosols and the impact that has on minimizing cross-contamination. Internally, we've been utilizing a third-party microbiological visualization technology. It essentially allows us to illuminate viable C. diff spores in the healthcare environment, and I know that's one of many things we're tackling, but knowing how long it lives on high-touch surfaces, to me, it's a great starting point and could be a game changer in the future. So it identifies where spores are actually present, viable spores, that is. And through this work, we've realized two high touch surfaces that I wouldn't say are neglected, but there's room for opportunity for surface measurement and disinfection. And those two areas are shower fixtures, which aligns with what Barbara mentioned about her tackling the bathrooms. And the other item are glove boxes. And through this work, it's actually prompted some of our partner organizations to move the glove boxes outside of the patient room so it minimizes cross-contamination. So I just wanted to briefly mention that. We talked about IV poles. We think about workstations on wheels and the impact not cleaning and disinfecting those appropriately could have on cross-contamination. So there's just a few things I'd like to add to this conversation. But this is where I think the rubber meets the road is how are we truly cleaning and disinfecting for maximum effectiveness? And I think we're going to get into that a little bit now.
All right. Thank you, Sophia. Well, besides tackling surfaces, we also have air as a concern. So I guess next we want to talk about what role indoor air plays in disease transmission and if there are any HVAC adjustments that can kind of help out facilities. I'll start this conversation off with Barbara.
Thanks, Kathleen. Air and water and surfaces are kind of the three things. And so it's great that you're bringing this up because we just talked about aerosolations and how things can be transmitted through sneezes and coughs that aren't, sort of done right, and just the air that goes around. It's really looking at what kind of a system do you have? How old is it? Has it been brought up to speed? But the most important things are the filtering of the HVAC as well as freestanding filter devices that can be put in portable places like waiting rooms for ED and clinics and things to help with to overcome things, but you have to look at the exchanges of air you're getting. There's certain amounts that are standardized for certain activities. You have to be sure you're reaching those. You always have to check on all those things, but it's all the filters, and the filters keep getting more and more sophisticated at trapping particles that are even smaller and smaller in order to minimize the transmission of those.
All right, thank you. Sophia, air transmission of viruses. Your thoughts?
Yeah, I mean, all the literature points to, airborne and contact transmission being viewed as interconnected. I know when it comes to outbreak outbreaks, spaces with poor ventilation are repeatedly implicated in higher attack rates of respiratory viruses compared to well-ventilated spaces. Specifically, when it comes to HVAC or even in specialty areas like the perioperative environment, we've actually deployed low-level dry hydrogen peroxide technology. It's not a turn on once and walk away device. It runs continuously in occupied spaces. It works at concentration levels well below OSHA exposure limits. And the goal really isn't to replace what we're doing. It's how do we reduce background microbial burden in the air and expose surface disinfection, cleaning between cycles. So I think there's a lot of studies to support it. But even when we think about it, I talk to Barbara at times about sustainability. I think there's a play here as well. If we want air and odor control solutions that don't introduce unnecessary chemicals, ozone, or even excess energy use, I think we need to prioritize that. There are opportunities from a pest management perspective, even that we can bring into play. And then if we look at malodor control as well, how are we minimizing the VOCs that go into the air, which will ultimately negatively impact the environment? So outside of directly asking about HVAC, I think there are other avenues in which we can really enforce strong air quality protocols.
Thank you, Sophia. Rodney?
Yeah, just real quickly, this isn't one of my expertise areas, but certainly I've learned a lot, especially during the pandemic. And sometimes when I'm again thinking of an analogy for the general public, I always think about what we do as professionals, especially in the laboratory. We're often wearing PPE, so we might have different types of respirators or different types of filtration to protect us from really dangerous pathogens. We know that's a absolute necessity when working with really high level 3 and 4 viruses and so forth. So think of your building's HVAC system is needing filtration, right? If you really want to help filter the air that's coming out into the public, you really want to start considering high efficiency types of filtration. And there's a number of them out there, I know. And then just like anything else, you want to conduct regular kind of strict maintenance. You want to that continuous checking of things because filters get used up pretty quickly. And then also controlling humidity for things like mold and other things that can happen in older buildings or any building for that matter. Humidity and moisture, as you know, is always a danger when that occurs, not just in walls and on drywall, but within the HVAC system. So there are ways to deal with this. There are things we already mentioned, filtration. Some places now are talking about UV germicidal lights, and just any number of ways to ventilate that area so it's not staying humid. But definitely talk to experts who know what they're doing in this area when you're looking at building, kind of refitting things or brand new buildings, because you can really help limit some of that air, increase your air quality to be better.
All right. Now we're going to go from talking about kind of some facility issues to actually personal issues and how people's hygiene and use of PPE can help with transmission of viruses. So we'll start off with Sophia. How do you enforce hand washing and what types of PPE do you recommend?
Sure. So I think when it comes to frontline team members, especially housekeepers, we have to reiterate that enforcement isn't about catching people doing something wrong. It's really about building reliable systems. So of course, we would encourage quality assurance checks regularly, direct observations, have it documented, shared appropriately. But I think those observations need to be captured digitally and reported regularly. I think when this is visible, it becomes part of how you operate. Many times we think of older facilities, we have to make sure we do audits to ensure that hand hygiene stations are accessible wherever the work is happening. From our perspective, we always do regular inventory to make sure supplies are stocked consistently. We have to make sure reliability doesn't drop in this sense. I think a lot of our top performing partner organizations, they do use wearable high-end hygiene reminder systems. Again, not punitive, but I think they're empowered to wear them, hold themselves accountable. Because I think if it's less about surveillance and more about real-time behavior reinforcement. That's where we start to see the behavioral change. Relative to PPE, whether it's infection prevention or occupational safety, I think structured risk assessments are always at top of mind, especially when we come into partner. But in practice, we standardize PPE based on facilities, protocols, isolation signage, and what have you. But when it comes to specific tasks, we have had situations where we make PPE task specific because we know routine cleaning may not require the same protection as cleaning after, let's say, a vomiting event or handling regulated medical waste or performing bathroom cleaning and disinfection where there may be like higher splash risk. So it can be situational, but at the core, we always align with that of the organizations that we serve.
All right, thank you, Sophia. Next, Rodney, hygiene. How is it so critical?
So, I mean, this is that particular issue that I think all IPs and healthcare professionals deal with, hand hygiene. It goes without saying, and Sophia and the others have talked about this a little bit. You really need great, sustainable monitoring of hand hygiene. It's like anything else. Most people will learn how to do something or being reinforced on something, and they'll do it for a while, and then time gets short. There's emergencies, and they may get a little bit lazy on proper gloving and donning and doffing or hand washing or different types of agents that are used. So it's really about the culture, I think, that you create in your facility and with your personnel, and trying to really emphasize how that saves lives. I talk about this with my medical laboratory science students who aren't in direct patient care, but they are sometimes walking in to do phlebotomy, or they're walking in to do spinal taps and help do things like that. So any patient interaction or any interaction with the public in any facility where hand hygiene is not being sustained and maintained is always going to be problematic. And then for PPE, we could probably spend a whole webinar talking about this, but I mean, the basics truly are thinking about, things like gloves, gowns and aprons, masks, the difference between surgical mask and respirators. It can matter with respect to what you're working with, eye protection, face shields, and all of those things that we know that are out there. And so just being sure, if you don't know exactly what to utilize in certain instances of certain pathogens, that you should be listening to experts and talking to experts about certain types of PPE. We fell into a little bit of a problem here, I think, in the country and maybe globally, when we got into the kind of this war over masking and not masking. Most of us that work in this area, I've been working in this area for 30 years. I am never going to walk into a level 4 laboratory and work in a way that's going to put me at danger or my family. And so when you're working with unknown agents, you really want to be careful and think about how critical that is to protect not just yourself, but your patients and your colleagues and those that are with you. So it is important to understand the scientific evidence around those types of things.
All right. Anything you want to add to that, Barbara?
I'll add a little bit about the hand hygiene and hand washing. If you read the articles over time, including just, a few months ago, it's a mishmash of, do we put all the bells and whistles on that hand sanitizer dispenser so it counts when you're there and when you're not there, and you have to, do your ID tag versus what's really going on there. But I think we have to think about several conditions. One is, we talked about norovirus earlier, and Rodney alluded to it. It has little effect. Hand sanitizers have little effect on norovirus. So you have to use soap and water. So you have to have a critical awareness of what's really going on. Second thing is, you should be doing some sort of sanitizing, but also hand washing often enough during the day that it's not just about, well, I hand sanitize, so I'm good for the day, and that's all I need to do. The other point to that is if you are going to need soap and water hand washing with approved soap and water that we have is you need to have a place for people to do it. So much in these newer hospital designs and things that might not be taken under consideration. And I wouldn't suggest that you go into the restroom. There I am again with the restroom in a patient's room or whatever, because that may not be the most sanitary for you as a healthcare worker. But coming from an academic medical center, which there would be 10 residents or medical students doing rounding, and they're going room to room, you have to think of all those consequences and things. So there's a lot to take into consideration, but I do believe that the best thing is trying to hardwire hand sanitizing, cleanliness, soap and water, when is effective, when you should do it, how often, and then have appropriately have lotions that can effectively be used against the residual effects of some of the hand sanitizers, CHG, etc. Don't just bring some lotion from home and think it's going to be good for your hand. So you got to balance it all.
All right. So, and we're going to come on to our last panel, and we'll be talking a little bit about technology solutions. So, are there any cleaning and disinfecting technologies that you guys have personally found effective? And what about for facilities on a budget? They can't be buying everything. What one technology would you recommend? And we'll go with Sophia.
Man, you have me stuck with one. I think, as Barbara alluded to earlier, I think when we think about technologies that effectively reduce pathogens, I do still believe that the foundation is still chemistry, and more specifically, properly formulated EPA registered disinfectants applied correctly. And she said it perfectly. I mean, that's where the rubber meets the road. I know quats and sodium hypochlorites are still most widely used across the country, but I really believe that accelerated hydrogen peroxide formulations are a good example of why formulation science matters. It's not just hydrogen peroxide doing the work, it's the surfactant system within the formulation. It lowers surface tension, which improves wetting and allows a disinfectant to spread evenly across the surface. It penetrates microscopic irregularities. I think that improved surface contact increases the likelihood of achieving the required microbial log reduction within a labeled contact time. So I think that's really the foundation we have to appreciate. There's so much science behind adjunct room disinfection technologies like UVC, and there's more out there now. I think you should pay attention to the chat if you haven't already. I think what Rodney mentioned relative to emerging technologies is critical in the future of cleaning and disinfection, whether it's cold plasma systems, which show promising lab antimicrobial activity. I'm thinking of, I think he mentioned self-disinfecting surface materials like copper alloys and photocatalytic coatings. That also has great research behind it. I think this additional layer of environmental control will help really supplement a disciplined cleaning and disinfection protocol. And then budget, which I don't love to hear budget, but that's the reality that we live in. I still do believe that if you're operating on a limited budget, the recommendation from my perspective would obviously be to invest first in an objective cleaning verification and protocol optimization solution, because again, that's the foundation which we build upon.
All right. And Barbara, let's talk technology.
So technology is part of what I think of as a whole bundle for effective cleaning and disinfection. So we can have the surfaces, other materials like over the bed tables, faucets made out of, copper and different materials. We can have UVC lights that you can put in rooms. Some of them are even part of a light fixture in a room and can be turned on at various times. Not everything knocks down pathogens to that 99.9999% level, and that's where you really want to get at some point. Any of the technologies must be bundled with, as Sophia so elegantly said, good cleaning. So you're knocking down bioburden and other, maybe blood and other items from the surfaces, and then you disinfect with the right disinfectant, the EPA versus the surface versus what are the bugs and things you expect. So it's like a big bundle. But one of the things I think the technology for a budget could just be at least AI. We had to mention it at some point. I'm the first one to mention it today. Um, AI being able to sort of scrub through all of your current records going on between the lab results, what's going on with patients, etc., and try to capture some of these diseases before they happen, and so that you know what you're dealing with, and maybe you're not having to deal with as much MRSA and things like that. So that's one high-tech thing. I would say that good filtration systems, as well as the detection systems that Sophia did, but everything needs to be in a bundle, and you have to have an approach that everybody is at the table in a hospital or other healthcare environment that's going to be involved in this, and all give their opinions of what is doable, why are we doing it, and you get around that sort of dollars and cents, knowing that if we do X, Y, and Z, this is my value analysis hat. If you're looking at it from a clinical and operational standpoint, then the dollars you spend, you will get that value and return on that investment by keeping your patients and your staff safe. So I think it's a bundle, and I'm not an insurance salesman.
All right. Well, we're glad you're not insurance because you're invaluable to infection prevention. Anyway, our last slide is we're going to give people a chance to ask and answer questions. My colleague, Elizabeth, is going to pop on and she's going to help out with managing the questions.
Hello, everyone. Thank you to our panelists. Great insights already. And I've gotten a couple on C. diff, so I think we should start there. Barbara, I think I'll start with you here first. What are the most important surfaces to disinfect after a case of C. diff? And should curtains and walls be included with all of that?
So great question, because there's a lot in the literature about it. And one of the big things that is known to transmit C. diff to other patients are the surfaces they lay on. Some people call them mattresses. We call them kind of surfaces because they have an outer cover. And then there's the mattress surface underneath. But between the bed and the mattress is where you get the most transmission of the actual spores. It's not really the organism so much, but it's killing the spores. So curtains, however you do disposable or reusable curtains, walls, there should be a protocol. And what helps to sort of predict those things is if you do some testing in a room afterwards for your own, sort of level of C. diff that you might have, looking for the different spores and things. If you can do that and understand, yes, it's spreading to lots of different places. I will go to the restroom again. Is that because of the nature of the issues with C. diff? That's really, really important. At least it is treatable, but it's the spores that are left over and the residual in the mattresses that are probably the higher problem.
Okay. Sophia, anything to add?
Yeah, perfectly stated. I think in a C. diff case, curtains within the patient zone should be changed or laundered as part of terminal cleaning. Many facilities incorporate curtain replacement into their discharge protocols for that reason. I know walls are different. Routine disinfection of walls is not truly supported by research unless there's visible contamination, as Barbara mentioned. Most studies show that walls are less frequently implicated in pathogen transmission, as she mentioned. I think walls immediately adjacent to the patient bed or bathroom area, particularly if there's been a splash or visible soil or known contamination, should be clean and disinfected. And I think we have that recorded on record.
And then another question came in here too. Would you recommend using hypochlorous acid hand sanitizer over alcohol-based hand sanitizer to kill the norovirus? Barbara, I don't know if you want to touch this one.
Yeah, we covered that like 22 minutes ago. Is that hand sanitizers, no matter what formulation, are really not recommended for norovirus because they don't do much to the virus themselves. So you need soap and water. And
Okay.
hypochlorous right now, if you look at the CDC, they still support alcohol-based hand sanitizers and don't really support the hypochlorous for hand sanitizer. Surfaces, yes, but not so much hand sanitizing.
And then, Sophia, what tests are useful to determine if surfaces have been effectively disinfected?
This is another one that keeps me up at night. I don't think I get much sleep, my my friends, but I mean, truly, no single test proves disinfection in isolation. I think each tool measures something slightly different. The strongest programs combine not only performance verification, but scientific validation in partnership with IPC. So we continue to see the use of ATP swabbing, fluorescent markers. I mentioned the one-of-a-kind microbiological visualization tool. There are like thermal imaging systems out there, but I think as long as it can be proven and validated and tied to improvement in cleaning and disinfection of particular areas and surfaces, then it should be within your repository of solutions to test.
Okay.
I do have one little thing to add to that. Hydrogen peroxide-based disinfectants are known to mask true results for ATP because it interferes with the enzymes that are used. So you might get a false negative that there are no signs of bacteria or other organisms there.
And we just had a question come in from Donna about electric static spraying machines. Are electric static spraying machines a good disinfectant? Barbara or Sophia, would you like to tackle this?
Sophia, why don't you go first and I'll see what's left at the end there.
Yeah, I think about the peak of COVID and supporting the Javits Center with our EVS operators and primarily using electrostatic sprayers at the time because we were all trying to find our way to minimize the spread of this thing. So I think there is science to back it up. I think it depends on how they're used, what disinfectant is applied, the environment in which it's utilized. It's not something we promote within our repository today because of the limitations, but I do think that there's enough science to back up the functionality and science behind it. But Barbara, I'd love your perspective on this because
Yeah,
again,
well,
this is one I toggle with.
yeah, you hit on the thing is between the different technologies, it depends on how it can actually reach all of the surfaces that are needed to be covered. And necessarily there might be shadow areas or difficulty in, does it do 180 degrees to 70? What is really happening in that area in which they're utilizing it? And is it going to be as effective as you need it? Or is it something to knock down most, but you need to get into certain places with other modalities?
As Kathleen mentioned, we're getting lots of great questions in. I have about 20 more too that people submitted. Please feel free to reach out to Kathleen and we will get these answered for you. So thank you very much for being so interactive. I'll turn this back over to Kathleen.
Yes, thank you very much. I put my email address in the chat. If you have any questions and you have a favorite panelist or one you think would really answer your question, feel free to email me and I will make sure that they get it. So thank you, everyone. I wish we had more time, but I appreciate everyone signing in and hope you've learned something valuable. I certainly have. Good afternoon, everyone. Bye-bye.
Thank you so
you.
much. Take care.